بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the last or the third part of the topic imaging of the white matter diseases, and we have discussed in the first part of this talk the primary white matter lesions, which are named as leukodystrophy, and we have handled these six pathologies. Then in the second part of the talk we have discussed the acquired white matter lesions, and we talked about MS and some of the traumatic and inflammatory white matter diseases. And in the last part of this talk, we are going to discuss about 9 diseases, which are the 4 lesions included in the primary white matter lesions, which are the phenylketonuria, the methyl melanotic acidemia, the choleric aciduria type 1, the maple syrup urine syndrome, and also we will discuss disorders of both white and gray matter, including the Leigh's disease and the Melas syndrome. And finally, we will talk about Huntington disease and Farr disease, as well as the Wilson disease, which are disorders primarily affecting the basal ganglia. Starting by phenylketonuria, and this is an autosomal recessive disorder, and the incidence is 1 in 14,000, which is considered a relatively common disorder. The patients are usually normal at birth, and there is an enzyme deficiency which leads to inability to utilize some of the essential amino acids. And we should know that phenylalanine is only obtained externally, and it is not normally produced in the human body. Patients with phenylketonuria may suffer from mental retardation and some seizures, lack of coordination, hyperactive behavior, and hyperreflexia. The manifestations are usually non-specific, but it can go in the differential diagnosis of extensive basal ganglia and white matter calcifications. On the CT scan, you can see hypodensity within the white matter, some atrophic brain changes, but the prominent feature of this disease is the bilateral, almost symmetric basal ganglia calcification, as well as affection of the white matter in the frontal and occipital subcortical area. As you can see here, this is the lentiform nucleus, the part of the thalamus, and also the caudate nucleus and the frontal and occipital subcortical white matter. In MRI, and you can see the affected white matter will show hyper intensity in the T2 and the FLAIR weighted images, and there is some relative sparing of the subcortical U fibers. MRI is more better than CT in assessing the efficiency of dietary treatment. And these patients should receive the needed phenylalanine, which is essential for growth. This is the normal blood level of phenylalanine, and these patients should have a lot of cereals, starches, fruits, and vegetables, and they should avoid the high protein food such as meat, fish, poultry, eggs, and the cheese, and also milk. And the second disease in this group is the maple syrup urine disease. And this is an autosomal recessive disease with compared to uh, phenylketonuria, it is far rare, and the incidence is 1 in 225,000 population, and this disease will result in inability of the body to break down certain parts of the proteins, and this will result in urine which can smell like maple syrup, and hence the name of the disease. Without treatment, the patient will die within 1 year, and the main manifestations in imaging in these patients are just the diffuse brain edema affecting the cerebellar white matter, the brainstem, cerebral peduncles, and the posterior limb of the internal capsule. You remember that the previously mentioned sites are normally myelinated in the newborn, but if you look here and you can see that in this series of T2 weighted images, there are high signal intensity in the structures that are normally myelinated in the newborn. And to remind you, with these structures, they include the medulla, the dorsal aspect of the midbrain, the posterior limb of the internal capsule, and the anterolateral aspect of the thalamus, as well as the deep centrum semi-oval. These structures, which are normally myelinated uh, at birth, they are appear of a very high signal, and this means that they are affected by vasogenic edema. While the unmyelinated white matter, normally it will appear of high signal due to the increased water content, as I have mentioned before. And this lesion is treated by intravenous protein-free diet and much of fluids, sugars, and maybe some fat. And this diet should be applied for life, and this will need some supervision by the dietitians, and the parents' cooperation are mandatory in order to prevent CNS damage if the patient did not stick to the dietary treatment. The third of this group is methylmelanotic acidemia, and it is also an autosomal recessive disorder with an incidence of 1 every 35,000 population. Sorry. And this, the body is unable to process certain proteins and fat probably, and this will lead to accumulation of harmful amounts of organic acids and toxins in the body. And this amino acidopathy will affect the mitochondrial activity, leading to accumulation of methyl malonites in the blood and urine, and this will result in hyperammonemia and severe ketoacidosis. The main and the characteristic imaging finding of this disease is the presence of bilateral, almost symmetrical hypodensity of the globus pallidus on CT scan. And these lesions will appear of low signal on T1 and high signal on T2 weighted image. This is a peculiar finding on imaging in this particular disease, which is methylmelanotic acidemia. If you look here, and this is T1, low signal intensity in the globus pallidus, T2, high signal intensity, and the FLAIR images is mixed low and signal intensity, and there is no diffusion restriction. And This will exclude, of course, the possibility of an infarction. The absence of diffusion restriction will exclude the possibility of acute infarction. In glutaric, the fourth type of this group is the glutaric aciduria type 1, which is also an autosomal recessive disorder of a rare incidence, as you can see, and it affects the mitochondrial activity due to deficiency of an enzyme, which will lead to accumulation of glutaric acid in the brain and the body fluids, including urine, and hence the name glutaric aciduria. These patients will appear asymptomatic early in the neonatal life, but they may have some macrocephaly, and the initial presentation of the disease may resemble the viral encephalitis or the acute demyelinating encephalomyelitis, and this will be followed by extrapyramidal symptoms. And if you have seen one of these cases, you are not able from the clinical picture to discriminate actually between this disease and an attack of viral encephalitis. Then the imaging findings are also characteristic. They include number one, bilateral frontotemporal atrophic changes. The frontal lobes and the temporal lobes are relatively atrophic. And consequently, the sylvian fissures are wide and broad, giving the brain the appearance of bat's wing configuration. Then the interhemispheric fissure will be prominent, and there may be some hypodensities within the lentiform nuclei. By MRI, you will see the same manifestations, but you are able to detect abnormalities in the basal ganglia. There is frontotemporal atrophic changes. There is bat wing dilatation of the sylvian fissures, and there are high signal intensities in the basal ganglia, as you can see here, and these signal abnormalities or these lesions will show restricted diffusion. Then meaning that these lesions are actually ischemic changes in the basal ganglia, and they represent infarct. And this is an example of glutaric aciduria type 1 with temporal lobe atrophic changes, prominence of the sylvian fissures with bat wing configuration, and bilateral ischemic changes in the basal ganglia, including the putamen as well as the head of the caudate nucleus. Then this child with seizures and a delayed milestone showed the classic appearance of glutaric aciduria type 1, where there is a frontal and the temporal lobe atrophic changes. There are prominence of the sylvian fissures, and as it is written here, the biochemical investigations and subsequent neuroimaging clinched the diagnosis of glutaric aciduria. And this is glutaric aciduria type 1 in a patient 7 years old with developmental delay or delayed milestones and mental retardation, showing some of the classic appearances. Prominence of the sylvian fissures, this is one of the prominent features of this disease, and there are T2 high signal intensity in the globus pallidus as well as in the optic radiation, the white matter. These lesions will show restricted diffusion in diffusion weighted images, denoting they are of ischemic nature. And to sum up the previously mentioned data about the four diseases, the phenylketonuria, all the four lesions are autosomal recessive. The most common one of them is the phenylketonuria with this relative common incidence. The main problem is the inability to utilize amino acids, and the disease will present at the age of 3 to 6 months with white matter and basal ganglia calcification, which are better seen by CT, of course. The treatment is to have diet rich in phenylalanine, which is not sensitized inside the human body but is obtained from external diet. And the diet should be rich in fruits and vegetables, and you avoid the proteins in this diet. The maple syrup urine disease is also an autosomal recessive. It is rare. The main problem is inability to break down certain proteins. The presentation is early in the early days of life with diffuse white matter edema indistinguishable from any other white matter edema, and the treatment is also related to diet, which may need to give the patient intravenous protein-free diet, and you may need also to have dialysis in order to remove the waste products resulting from the inability to break down these proteins. And methylmelanotic acidemia is also an autosomal recessive. The main problem is the inability to process certain proteins and fats. The disease presents early in infancy. The main imaging finding is almost a characteristic where you can see bilateral symmetrical globus pallidus lesions. These lesions will appear hypodense in the CT, low signal in MRI T1, and high signal in MRI T2 and FLAIR with no restricted diffusion, excluding that these are an infarct. The diet treatment include low protein diet, some calcium, a lot of vitamins, and one of the important issues here is to avoid long fasts. That is to say, you should give the patient frequent meals and even he is not hungry. Then glutaric aciduria type 1 is also an autosomal recessive disease. It's relatively rare compared to the rest of the lesion. And this is the main problem here is enzyme deficiency leading to accumulation of glutaric acid in the brain tissue and body fluids. The presentation is early in infancy at the age of or after the age of 3 months. The imaging finding is also characteristic in the form of bat wing appearance of the sylvian fissures, frontotemporal atrophic changes, high signal intensity in the basal ganglia, which will show restricted diffusion denoting ischemic changes. The diet treatment of these patients will include low protein diet, a lot of fluids, a lot of vitamins, and also very important is to provide frequent meals, and this treatment is long life and to avoid the complications of this pathology. Then we came to the lesions affecting the gray and white matter as well as those affecting the basal ganglia. The gray and white matter lesions will include Leigh's disease and Melas syndrome. The Leigh's disease is a subacute necrotizing encephalopathy, and it is inherited as autosomal recessive or X-linked mutation within the mitochondrial DNA. The onset is usually before the age of 2 years, but as in every disease of the white matter, there may be some juvenile and even adult forms. Patients with Leigh's disease will present by muscle weakness, dystonia, vision deterioration, ataxia, tachypnea, seizures, and this occurs from respiratory failure within few years of life. Laboratory findings will show elevated CSF lactate. Then the lesions of Leigh's disease will appear of low signal in the T1, high signal in the T2, and flare. In the CT scan, they will show hypodensity, and the sites are very characteristic for the diagnosis of Leigh's disease. They involve the putamen and the globus pallidus, the basal ganglia, the caudate and the thalami, and the periaqueductal gray matter and the brainstem. And if you remember that we have discussed a disease in the second part of this talk, which is the vernix encephalopathy, which also affects the periaqueductal gray matter and the brainstem together with affection of the mammillary bodies. Then vernix encephalopathy occurs at relatively a higher age, and this Leigh disease will present during the childhood. Then if you look here and you see the affection of the posterior part of the brain stem, the affection of the basal ganglia, and this is also an example of Leigh disease T1 and T2 weighted image with diffusion weighted images, where you can see the T1 hypodensity within the basal ganglia, which became hyper intensity in the T2 weighted images with affection of the periaqueductal white matter, and all the lesions showed restricted diffusion, as you can see here. And this is also a case of Leigh disease in a child 2 years old with affection of the posterior part of the brain stem, the periaqueductal area, the medial aspect of the thalamus, almost similar to that of the vernix encephalopathy. And this is the affection of the periaqueductal area with Leigh disease. And this is also Leigh disease. You see affection of the posterior part of the bones, affection of the region around the aqueduct of Sylvius, and the medial aspect of the thalami. Then it's important to differentiate Leigh disease from vernix encephalopathy, since they may have all some similarities in imaging findings. But the involvement of the mammillary body, which is a prominent feature in vernix encephalopathy, is not seen in Leigh disease. An enhancement of the lesions will appear in vernix encephalopathy, not seen in Leigh disease. Also, the possibility of hemorrhage is more common with vernix encephalopathy. Then we came to the MELAS syndrome, which is the abbreviation of mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. This is a familial disease, and the main abnormality in this disease is the presence of cerebral infarction. And there is always a debate about if these cerebral infarctions are due to ischemia or due to this metabolic abnormality. But the CT and MRI findings are non-specific. They show only cerebral infarction, which is commonly seen in the occipital lobes, but can occur in any part of the brain. And in this disease, the two main sites that are affected are the brain, leading to encephalopathy, and the muscles, leading to myopathy. And the patients will present with some seizures, headache, and muscle disease with a stroke-like appearance in the CT or MRI imaging. And if you look here, and you can see some calcium in the medial part of the lentiform nuclei, and you see an ischemic changes in the occipital lobe on the left side. This is T2 and this is T1 post contrast. There is no enhancement in the lesion, but there are some criteria that can enable you to predict the possibility of MELAS syndrome. Number one is the presence of these ischemic changes in a relatively younger age, because the patient with MELAS syndrome usually present before the age of 40 years. And number two is the elevation of the arterial and the CSF levels of lactate. And number three is the presence is the is to have a muscle or brain tissue biopsy to confirm the diagnosis. Then we have three findings. The one in the imaging, which is ischemic lesions before the age of 40 years. One in the lab, which is elevated arterial and CSF levels of lactate, and also to confirm by the biopsy of the muscle or the brain tissue. Then, as I have mentioned, there is an ongoing debate about whether the stroke-like incidents in MELAS syndrome are ischemic or metabolic or even both. The lesions will appear hypodense on the CT scan. They will appear of high signal in the T2 and flare-weighted images. If you inject the contrast, they may show luxury perfusion or chiral pattern of contrast enhancement similar to any infarction. And if you have the diffusion weighted images, they will actually show restricted diffusion. But if you have the MR angiogram, then you will see that the vessels are normal, both the arteries and the veins. And this is a child, 10 years old, with an occipital infarction on the right side, low signal in the T1, high signal in the FLAIR and T2 weighted images with restricted diffusion. The presence of ischemic strokes in a relatively younger age may have the suspicion of MELAS syndrome, which may be confirmed by the presence of lactic acidosis and also may be confirmed by muscle or brain tissue biopsy. Then we came to the Huntington disease, and this is an autosomal dominant disease, and it typically presents by the age of 30 to 50 years. And the main imaging finding is the severe atrophic changes of the basal ganglia, especially the caudate nuclei. And this is the appearance of the basal ganglia in a normal brain sample. And here you can see the atrophic changes with consequent dilatation of the frontal horns of the lateral ventricles. Patients with Huntington disease presented by progressive rigidity and the abnormal movement, as you remember, what is known as Huntington chorea, with some dementia, psychosis, emotional liabilities. Then this is the difference between normal brain and the brain of Huntington disease, where you see the basal ganglia, especially the caudate, is atrophic, and the frontal horns of the lateral ventricles are considerably dilated. And this is also an example of a patient who was diagnosed by genetic testing to have Huntington disease at the age of 30 years, representing with brain atrophic changes, which are considered too early for this relatively young age, with considerable dilatation of the frontal horns of the lateral ventricles. And there are a lot of measurements for this disease, but actually we rely upon the clinical data and the imaging findings of considerable atrophic changes in the basal ganglia, especially the caudate, with the box-like appearance of the frontal horns of the ventricles. Then we came to Fehr or Farr disease, and this is a congenital disorder which may appear as an autosomal dominant or recessive inheritance. The main feature of this disease is the bilateral symmetrical calcification of the basal ganglia, which may affect also the cerebral and the cerebellar regions. Then the diagnostic criteria will include this is a familial disease, and there should be a positive family history, and the presentation is in the fourth or the fifth decades, or maybe earlier. There is progressive neurological and neuropsychiatric manifestations with typical signs of calcification, including the dentate nuclei and the cerebellum, the basal ganglia in the supratentorial area, the caudate, the lentiform, the thalami, as well as the white matter. And you see here, there is a bilateral symmetric calcification of the dentate nuclei, the caudate head, the lentiform nucleus, the putamen and the globus pallidus, the posterior aspect of the thalami, and the subcortical white matter. Then there are a lot of diseases that can produce basal ganglia calcification, like the hypoparathyroidism and pseudo hypoparathyroidism, and any parathyroid abnormality, also the thyroid diseases and Parkinsonism and the radiation, many diseases that can produce these basal ganglia calcification. So we should exclude other causes by the normal biochemistry, including calcium and phosphate metabolism, no clinical feature of systemic illness like vasculitis, for example, no clinical features of mitochondrial disorders like phenylketonuria, and no infection or toxic causes are identified. Then the CT finding is characteristic, where you can see extensive, almost bilateral symmetrical basal ganglia calcification affecting the caudate, the lentiform, the thalamus, and the dentate nuclei in the cerebellum, as well as the subcortical white matter. In this disease, it is stated in the literature that the globus pallidus is affected first, then followed by the rest of the sites for calcium deposition. And you know that calcium in MRI will appear in some cases black in the T1 and black in the T2 weighted images. But in other situations, the calcium will appear of some increased signal in the T1 weighted image, like you see here, and decreased signal in the T2 and the flare weighted images. And this is also an appearance of FAR disease, where you can see calcium in the basal ganglia by MRI. In this MR example, the calcium appears of low signal in the flare image and in the T2 weighted image, but also the gradient image is very sensitive for detection of calcium in the blood. And you can see here the calcification, especially in the posterior aspect of the thalami, which is also seen here. Then we came to the Wilson disease, which is also known as hepatolenticular degeneration. This is an autosomal recessive disorder of copper metabolism, leading to copper deposition in various tissues like the liver, the brain, the cornea, the Kaiser-Fleischer ring, and the kidneys are mostly affected. The disease will be symptomatic by the age of 8 to 16 years. The main imaging findings are affection of the basal ganglia and the brainstem. Here in this disease, the lentiform nuclei are involved most commonly, then followed by the thalami, the bones, the midbrain, and then the cerebellar peduncles and the cerebellar nuclei. In this disease, you can see abnormal appearance of the basal ganglia in the form of high signal intensity in the T2 and the flare, low signal intensity in the T1 weighted images. And this patient is known to have Wilson disease on regular follow-up with worsening gait and the cerebellar signs. And this follow-up study shows diffuse affection of the brainstem together with affection of the basal ganglia. And these basal ganglia infection will not show diffusion restriction. And the imaging finding of Wilson disease may include number one, normal findings. Some cases will show normal appearance in both CT and MRI, or there may be a mild form of brain atrophic changes. But if you can see findings in this disease, you got bilateral basal ganglia, especially the putamen, hypodensities on CT scan, and these lesions will appear of high signal on T2 and the flare weighted images. Then there is also affection of the brainstem as well as the basal ganglia, as you can see here. Then to sum up, the five previously mentioned diseases, starting by Leigh's disease, and this is an autosomal recessive disease, then the onset of the symptoms will appear before the age of 2 years, although there is a juvenile and even an adult form. The main brunt of the lesions in MRI will be on the basal ganglia and the brainstem, with particular affection of the periaqueductal gray matter, which needs to be differentiated from Wernicke's encephalopathy. Then the Melas syndrome or the Melas disease is an inherited mitochondrial disorder. The onset of the lesions will appear before the age of 20 years, and this will be in the form of brain infarction, which is usually in the occipital region but can occur anywhere in the brain. As I have mentioned, there are three ways to confirm the diagnosis of MELAS. Number one, the presence of ischemic stroke in a relatively younger age. Number two, the presence of lactic acidosis. And number three, the muscle or brain tissue biopsy. The infant disease is an autosomal dominant or recessive. The onset is between the age of 30 to 50 years, and the main imaging finding is the presence of bilateral symmetrical basal ganglia calcification with calcium deposition in the white matter as well. Then Huntington disease is an autosomal dominant disease appearing between the ages of 30 and 50 years, and the main imaging finding is the atrophic changes mainly affecting the basal ganglia, mainly affecting the head of the caudate nucleus, and there is consequent abnormal dilatation of the frontal horns of the lateral ventricles, and also there may be atrophic brain changes as well. Finally, the Wilson disease is an autosomal recessive disease of copper metabolism leading to abnormal deposition of copper in the tissues, and the onset is usually at the age of 8 to 16 years. There is deposition of copper in the brain tissue, mainly in the basal ganglia, particularly the lentiform nucleus and the brain stem, and this will appear on MRI as areas of low signal in the T1 and high signal on the T2 and the FLAIR weighted images. And thank you very much. Alhamdulillah.